Thank you very much, Professor Recce, for this excellent presentation. Not yet, but what we have yet is Dr. Albert Gubern-Merida, who will talk about breast, who is from Nijmegen in the Netherlands. Albert, please.
Thank you for the introduction and for the invitation. It's an honor to be here. And I will try to give you travel through the different times about AI in breast imaging. So, as disclosure, I'm employee of ScreenPoint Medical, and to give you an insight of this, it is a company who develops AI for mammography and digital breast tomosynthesis reading, and it's basically a startup from the Diagnostic Image Analysis Group within the radiology department in the Radboud University Medical Center. And yeah, one of the founders is Nico Casemé, who has a lot of experience working with radiologists to bring this technology for the best use in clinical practice. If we talk about breast imaging, the application that comes into mind is breast cancer screening. And it has been shown that this helps detecting cancer at the earlier stage, reduce mortality, and also helps that the therapy given to the women is less aggressive. However, breast cancer screening has some issues, like training a radiologist that is very good at that. It's actually difficult because reading mammograms is difficult. We say also there is a lot of variability between the readings. And this is actually, if you ask me, it's a bit unfair for the women who are kind of in this lottery. And also, some countries have shortage of radiologists who cannot do these tasks anymore. So, yeah, these limitations were already there, maybe not so high as it is now. So that's why computer-aided detection was already there 20 years ago. This is actually a machine learning application, maybe actually the largest application applied to radiology today, where millions of mammograms are being read every year, especially in the US. And basically, for those who don't know, this application, when you hear about mammography CAD, means that the radiologist sees the mammograms, inspects if there is something suspicious, and at the end of it, what you could call a second read, they press a button, and you get some markers highlighting the areas that they should double inspect. Some radiologists were happy with it, some others were annoyed with the amount of CAD markers. If you look at the studies being published lately, actually there is only very little benefit on detecting the non-invasive disease. But actually the overall benefit is rather disappointing. One would expect more from these technologies. The reasons why they actually fail, well, one thing is that they only target the perception error, so just helping radiologists to double-check things that they might have missed. And this technology was developed 20 years ago, so the algorithms are actually outdated. And of course, when we talk about new algorithms, very powerful ones, we are talking about the deep learning revolution where we are now today, in which we know that we can train a classifier. If you have lots of data, very well labeled, you can have an algorithm performing much better than traditional approaches. And again, so since we need a lot of data to train this, mammography is the best candidate because there are millions of mammograms being generated every year. So one can train, if one is able to get all this data, one can actually train very good algorithms. If you look at the performance of these algorithms along the years and compare to how radiologists are performing, you can see that 20 years ago, this technology these algorithms were getting better until those CAD systems were into the market, business case was done, development was cut, so it was already a stop. So these algorithms didn't develop for a very long time. Now, a few years ago, we started applying deep learning to the problem of mammography, and we saw that these algorithms started to improve quite a lot. One example that we did at the Radboud when I was there, one colleague of mine, it was maybe one of the first attempts at the time on applying deep learning to mammography was, what he did is he split the image in different subregions, which is what you call patches. And the task of the classifier was mainly detect the patches that have a cancer versus the patches that they don't have a cancer. We train this classifier, we evaluate it, we get the traditional ROC curves, and to really understand what the area under the curve of this system meant, we asked radiologists to do the same task, read hundreds of patches and do the same. And quite surprising, we saw that the CNN at the time was already better than the radiologists. Of course, doing a task that is actually not what radiologists do in clinical practice. But yeah, nowadays these algorithms are evolving, so they don't work on patch base anymore. You can just fit the whole exam exactly what the radiologist is doing, and actually you have companies using this technology, bringing products into the market to really make the lives easier to the radiologists and also improve the care that we are giving to the women. So, how are these systems today, how they are performing? So this is a study that was made at the Radboud University Medical Center, in which they test a system, Transpara, which is the system that we developed at ScreenPoint, versus 101 radiologists. Actually, this study was actually non-biased. What they actually did is they collect a multi-vendor data set from different studies that for other scientific purposes, where they had radiologists reading, and they just basically run now our algorithm. And what we saw is, if you see the dark blue curve, you could see that actually it really falls on the ballpark of the independent performance points of the radiologists, which means actually it's comparable. If one simulates the average performance of the radiologists, then the conclusion was that the system was as good as an average one. We have seen also the same in another company based on the FDA, the study I did for the FDA, that indeed they also achieved a similar performance, that the performance was comparable to the radiologist. So yeah, this is basically where we are today. These deep learning systems are actually as good as the average radiologist. That's this, yeah, let's iterate about this. So this means we are moving to the part in which radiologists will be replaced. Well, everyone has said so. I'm not going to change that. I actually believe that it's not going to happen. And what we just need to do is use this very good technology of a very good quality to make life easier for the radiologists and also improve the care that we give to the women. And for that, we have different ways to apply this technology, which relates very much on how we can improve the workflow and also how we can improve the performance. One application is detection support, which is mainly what actually the CAD systems are actually doing. In this case, if one uses the deep learning algorithms, you can get rid of all these annoying CAD markers to really highlight the things that are very important to highlight. Another thing is decision support. As I said, the detection support is just highlighting what it shouldn't be missed. Decision support is more, radiologists might already see a lesion, but they want to have a second opinion from a system that is actually as good as a radiologist. So this is a study that was also done by the group in Nijmegen, in which they use our system when the system was used interactively with radiologists. The task of the radiologists who participated in this study was as simple as that. They had a mammogram, and as soon as they wanted to know the opinion of the system about a specific region, they could just simply click, and the system would just give a score of how likely the system thinks this is a cancer. And this could be performed anywhere in the image, in quite suspicious lesions, but some things that maybe are borderline that the radiologist is suspecting whether they should do a follow-up or a biopsy. The study showed that the radiologists improve both on sensitivity and specificity, so it's a good outcome of this. Another thing is the mammography wall is moving through the 3D mammography, which is what you call the digital breast tomosynthesis. And here, indeed, it might have very good benefit on the workflow, because digital tomosynthesis, it adds a lot of images to be read. It is shown that tomosynthesis really increases the cancer detection rate, so it helps detecting more cancers, but the reading time increases by a factor of 2. We have systems like the one of ICAD, in which they prove that by providing some region scores with region markers and exam score, they prove exactly what other systems prove, in which sensitivity and specificity gets better, and also reading time gets much faster. The same in our ScreenPoint, we also have a system of the same. Talking about workflow, you have a lot of markers detected in the 3D space, and this can really be used to go through all these slices in a much faster and even fun way than just scrolling through every single slice. Then another application is optimized reading strategies. And for that, you should know that all these AI systems, what they can do, since they can read the whole exam, they can produce a score which mainly says it's a risk of this exam having a cancer that can be detected. Usually these scores go from 1 to 10, 1 to 100, and you see that in the high categories, most of the cancers are grouped. So it's basically telling you that the highest category, the prevalence of cancer is much higher than in the lowest categories. One simple application of this is just put it in the working list. So depending on your mood, you start with the most likely ones, not likely ones. The manager of the department can maybe use this to split the task among the skills of the radiologist. That could be a possible application that we could do today. Another thing, if you really think about the screening and the lack of radiologists and the amount of images to be read, is replacing these second reading strategies. For instance, this is what happens in screening today, especially in Europe. You read a mammogram, you have two radiologists reading this. If they agree that it is a cancer, it's a recall. If they agree that it's not a cancer, it's a normal. If they disagree, they either meet or they just call for a third reader. You can see that a lot of radiologists in the loop. One possible way, just replace one with AI. Just replace the arbiter with AI. Or you can just go maybe more fancy things like, let AI decide how many radiologists I need to put to read these mammograms. Or even, we see that these AI systems are actually very good at detecting the normals. So let's AI just read the normals, which maybe it's not such an interesting job. And this, for instance, is one of the studies talking about independent tests where they use our system in the independent population of Swedish screening from the DBT mammal trial, in this case the 2D arm. They apply our system, and they actually saw that there are no cancers in category 1 and 2. From category 3 and 9, they saw that there are cancers, 31, but actually there were the less aggressive ones, and actually some that they were actually pretty obvious to the radiologists, so that's why they suggest single reading based on the observations, and in the highest category, double reading. With this approach, the reduction of workload is 50%. And if one thinks about tomosynthesis, this is an enormous gain that we could have. And last, when I have talked about the applications, I want to also talk a bit about implementation and usage, also talking about, typical questions that we get while talking to radiologists. This technology is very fancy, I believe, or not, and the results, how can I use it? Can I use it in my workspace? At the company where we work, we see that besides developing these algorithms, we also spend a lot of time talking to PACS, workstation vendors, to really put this into the workspace of the radiologist. Otherwise, indeed, as others speakers said, there is no point to using these systems. And you can see here some other examples. Another question which has already been raised, and also a question that we get, you show very good results on this population, but will it work in my population? Will it work in my images? This is also a very valid question that especially the users should really ask to the AI companies when they are about to use one of these systems. For instance, in mammography, we know actually that the mammography devices change. You have different spacings, different angles for the tomo, different processing algorithms that change a bit the flavor. All these changes for the radiologists, we know that, it doesn't change too much. But also we know for the algorithms actually might suffer quite a lot from this. So it's very fair that you ask for independent validation on the data set that you are using. And that's why when we talk about independent validation, what should be thinking about peer-reviewed. So things that the systems have been developed, and then an independent data set from a different population, maybe different vendors, actually proves exactly the same results were the claims of the company. So I'm coming to the end. So to summarize, I would say that AI for breast imaging at this stage focus on breast cancer screening, especially because breast cancer screening is where we can benefit the most, is where we have most of the problems regarding the workload, the lot of the radiologists, and it's actually where women can benefit the most. So that makes a lot of sense to push in this direction. If I say, if you ask me about the present, I think we already have tools there that maybe we can validate even further, but I really believe that we have tools that can help radiologists for a better detection support, better decision support, and for instance, prioritizing the work list. And if we look at the near future, we can think about these strategies, how to do the screening in a more efficient way. And here I say near future for two factors. One, because maybe we need more studies to validate exactly what is the best approach, and there is also, of course, a lot of bureaucracy in place to change these systems that have long for a very long time. last, yeah, we keep developing these algorithms, so we really believe that these systems at some point can get better and better, which means that your radiologists can benefit the most, and also women can benefit the most. Thank you.
Thank you. Thank you very much, Dr. Gubern-Merida, for this excellent presentation on clinical applications in breast imaging. Now, ladies and gentlemen, I do have good news and bad news for you. Let's start with the bad news. There will be no more images or movies from Professor Francone's presentation. However, the good news is that Professor Francone is here with us on the stage. And I would like I would like to give him some more time in the discussion. And I would like to start with a very, let's say, generic question. Marco, can you please tell us a little bit about approaches to AI in cardiac radiology, or AI algorithms that are used, or what the current status is and what the future may look like for cardiac imaging?
So thank you so much. And first of all, I apologize for this inconvenience. I will try to very briefly outline what are the peculiarities of the heart and the challenges that it poses to artificial intelligence. First of all, of course, it regards its anatomic peculiarities. We are dealing with very small vessels like coronary arteries. We are dealing with a structure which is not oriented perpendicular to the heart, and this poses a challenge if we want to, for example, create automatic acquisition algorithms. And finally, it is also characterized by its continuous motion with continuous inflow and outflow of pixels in the structure. So if I have to briefly summarize what are current applications, the pillars of artificial intelligence in cardiac imaging are basically aligned to what we heard from other lecturers. So it has a role for sure in the acquisition phase. If we think about cardiac MRI, as I mentioned, particularly for less experienced users, first challenge regards the acquisition on dedicated plans, and the artificial intelligence protocols are more and more going towards an automatic acquisition of cardiac imaging access, and this particularly works also in complex cases like congenital heart disease, for example. So this is very practical. Newly and less experienced user in cardiac MRI can use it for automatic segmentation. The second point, which is also common with other fields of or subspecialties of radiology, is of course segmentation. We heard a lot about it, but again, the assumption that the geometric structure of both ventricle is not perfectly aligned to any geometric assumption makes it a very interesting application. So what is currently happening in the field of artificial intelligence is that automatic segmentation of either coronary arteries and both ventricles is being proposed by different vendors, has become commercially available, works effectively, and there have been a lot of trials published from large biobanks, like the UK Biobank is one of those we heard about in the first session, and segmentation of images is perfectly effective for both ventricle in those settings. A third level or pillar of artificial intelligence in cardiac imaging goes towards the clinical part, and particularly in CCTA or CT coronary angiography on one side, and let's say deep phenotyping on the other side, and tissue characterization. For what it regards coronary arteries and segmentation and prediction of events, there is a lot of literature starting from radiogenomics that we heard about. So what is currently cardiac imaging looking at is to characterize risky lesions, and there has been a lot of work in this direction which tells